Sigur. Bine, mulțumesc, Lorena. Sorry, I have an important call. Okay, please tell me if you want to comment something or to discuss something about this specific subject. Was more, let's say, a lesson from from me to you, but still you can ask me or you can do something. Okay. After that, I prepare some few cases to discuss. No? Okay. If everything is clear, I'm glad. Let cases.
I'm sorry, before starting the thesis, my laptop shut down and restarted, and I wasn't able to actually say present when you made a presence.
Where are you? Your name?
Divan Maria Irina, group
Okay.
32.
Okay. Sigur, Maria.
Thank you.
Very good. Okay, let's discuss about these cases. We'll put them. Okay, good. Can you see the picture, the slide? Yes?
Yes, yes. Yeah.
Good. We speak about a patient, which is a lady, which is a smoker. And she has, you see, 30 minutes chest pain with dyspnea 1 week ago. Now he's in the emergency room. The hemodynamics, the vitals are like that, normal. Why? Tell me, who knows if why we measure the blood pressure during standing, and how is the result? Who knows? Who can tell me? Why it's less? It's smaller during standing. Hmm? Try to imagine.
Due to the autonomic nervous system.
You can put it like that. Actually, it's like that. Because of gravity, when a person is standing, the nervous system has to act very quickly to preserve the value of blood pressure during standing. And if it's less rapid, the patient tend to have low blood pressure when he's standing, and because of this, the patient can have dizziness or syncope actually, and this is called orthostatic hypotension. That means standing. Okay, and for diagnosis this, the difference between the systolic blood pressure in clinical position, lying, and standing has to be more than 20 millimeters. In this case, there are 15 millimeters. This is borderline. Some handbooks, some books, authors consider that if it's more than 10 millimeters mercury between difference, you can consider that it's orthostatic hypotension. That means this is borderline. It's important. And about the treatment, a patient with orthostatic hypotension, let's say this is one of these. Which drugs have to be avoided in this patient? Who knows? Think a little bit. Which kind of drugs? What mechanism maintain the blood pressure except the autonomic nervous system. What else? What is important for preserving blood pressure?
Drugs that affect contractility.
Not much, no. Usually,
Blood volume.
what, Mika?
I said the blood volume.
Yes, that's the most important because the most important thing is the preload in these patients. If the preload is decreasing, the risk of orthostatic hypotension is bigger. And what drugs affect preload? You
Diuretics.
about low volume and diuretics, it's a very clear example. What else which doesn't affect actually the blood volume but affects the preload as well? Think a little bit.
Nitrates.
Yes, indeed. That means venodilators and nitrates are the best example of this. And but not only nitrates. For instance,
Diuretics.
diuretics are decreasing the blood volume. ACE inhibitors are not only arterial dilators but venous dilators as well. And for this reason, even though most of doctors uh, don't think about this, these can cause orthostatic hypotension as well. Okay, the patient that we discuss, clinical, but still it's important, has a mild increase of troponin. And the ECG was like that. Tell me who want to tell me about ECG, but I prefer to be somebody else, not me again. Try to diagnose, to tell me what is on this ECG. Start from the beginning with everything, with QRS axis, with heart rate, with everything, the rhythm. I wait for it. Try, it's not that difficult. It's an easy ECG. Try. You have to know for the exam, you have to know for your future practice. Try. You can make mistake. I'm not. You can make mistake. It's not a problem. I don't give you a mark for this, but it's useful for you to try. I wait. Okay. I will try. Yeah.
It's a left axis and normal rhythm.
The left axis. Yes, it's a little bit negative, let's say, but it's more almost equal in AVF. If it's equidiphasic, I mean equal in AVF, at which degree do you consider that is the QRS axis? The precise degree? I don't know. Shalini or Prashalini? How is the name?
Prashalini.
Prashalini. Okay. Okay. Do you know? Who knows? Let's try to ask somebody. For instance, Joachim, do you know?
Could you repeat the question?
I ask if it's equidiphasic, that means equal in positive and negative in AVF, at which precise degree is the QRS axis?
90?
No.
-90.
It's
Zero.
actually 0.
Zero. Zero. Exactly. Zero. Zero. Very good. Okay. What else? Prashalini, you can tell me which is the heart rate?
It's almost like 75.
Almost how much?
Like 75.
Yes, yes. It's like that. Very good. And the rhythm?
It's almost like a regular rhythm.
It's a regular, but it's a P wave before every complex with a constant distance between P wave and the QRS complex. In this case, we call it sinus rhythm.
Mhm.
And if it's everything like this case, very clear about sinus rhythm, you don't have to say that it's regular. You just say that it's sinus rhythm and it's implied that it's regular. Okay, even though there are some cases, rare cases, in which the sinus rhythm is a little bit irregular. Okay, what else? Maria Rus, you can tell me something? I try to ask you by your group. Maria Rus, are you here?
Yes, yes.
Tell me something about something else about this ECG. What is wrong with this? The V2 is it's only a technical problem to be so waving. It's not the problem. It's a sinus rhythm with a normal in the normal quadrant, even though it's about 0 degree and with 75, let's say, heart rate. But something is not good at this ECG. What is
Inverted T wave.
okay? Where do you see inverted T waves? In which leads? You have to be precise usually.
In lead 1, lead 2,
Lead one,
or no, wait.
that's clear for me. One is those from upstairs. It's the higher one.
Oh yeah, sorry, no. Lead
Yeah,
2
yeah,
and lead 3.
exactly. Tell me every lead.
Mm,
It is clear they see,
Also in
no?
the precordials.
Yes. How is this inverted T? It's symmetrical or asymmetrical? What do you think?
Mm, symmetrical.
Yeah, it is symmetrical. Because when you have a inverted T wave, you have to decide which problem is, because it is not a specific problem, can be in a lot of disease. This is not specific, this inverted T wave. But if it's symmetrical, usually it's a pathological one. It's not a secondary wave, but it's a primary disease, and most of the cases is because of myocardial ischemia. What else, Marian? Look in V3, for instance. What else? There is something a little bit not normal in VT, except this inverted T wave.
Um,
Is the QRS wide? Whitish?
It's wide. Who is Joachim?
Nicholas?
Nicholas. Nicholas, it's not that wide. You, it's a little bit enlarged, but to be wide has to be more than 3 small boxes, which is not the case here. Yeah, about two to something, but no case is not more than 3. That means we don't call wide, even though it's a little bit enlarged. Um, okay, something else. In V3,
Is there a ST elevation?
I don't hear. Present it and tell me.
ST elevation, maybe? A little.
Yes, who you are?
Halime.
Halime. Yes, you're right. It's a mild ST elevation, but it's clear. It's not non-clear. Good.
Yeah.
Very good. That's this. That's the everything about this ECG. Let's see. Sorry. I'm trying to put it again. Sorry. Okay. And these look like the clinical part with the chest pain, long duration chest pain, the mild increases in troponin, these two, and the ECG are base for the diagnosis, which is acute coronary syndrome without ST elevation. Um, do you, you have the lecture about acute coronary syndrome without ST elevation? You know that there are two entities in this. One is unstable angina, the other one is non-ST elevation myocardial infarction. Which of them consider that is in this case? Review the case. I went back. We'll try.
Unstable angina
Unstable angina. Why you decide like that?
because troponin is mildly increased.
Yes, but on the other hand, if it's increased, it's already necrosis. Actually, Braunwald, you heard about this guy, Braunwald? Braunwald is a doctor, an American doctor, which has a very important book in cardiology. It's the main reference in cardiology. And he was specialized in unstable angina, actually in 1989, before you are born. He made some specific classification which was used a lot of time. But after that, let's say 9, 10 years ago, because troponin became more and more sensitive, and a lot of cases which previously were considered to have unstable angina now were classified like as myocardial infarction. And he made an editorial in the circulation, I guess, uh, which was called Requiem for Unstable Angina. That means there are less and less cases which are unstable but without myocardial necrosis. And actually, even though it's mild, we can tell that this case is non-ST elevation. Oh, it's a mistake there. Myocardial infarction. And STEMI, how we used to tell in our daily language. Okay, I'll come back to the ECG. This ECG is rather specific with this mild ST elevation and the negative T wave. It was described by a doctor, a Dutch doctor called Wellens. Probably most of the English doctors call it Wellens, but his name is Wellens actually. And and he associated this kind of ST change, the ECG, with acute coronary syndrome with LAD lesion, usually segment 2, but sometimes segment 3, LAD's left anterior descending artery lesion. And we call it this case Whelan syndrome. And we go further and we arrive to the coronary angiography that we have to do at a patient with acute coronary syndrome. And I don't know if you saw coronary angiographies maybe when I show you in a lecture, but this is the left coronary artery. It's a selective injection, the left coronary artery. And after a short left main trunk, the artery divided in left anterior descending artery or anterior descending artery and the circumflex artery. And on this left anterior descending artery, there is a mild abnormality here in the distal part, and this is magnification of it. And this, like a white line, it is called dissection. It's a spontaneous coronary artery dissection, which is not very frequent, but not as rare that we considered before, and appeared specifically in women and mostly in middle-aged women, and it's a cause of myocardial infarction or unstable angina. And this rare cause was here. And what do you think about the treatment of this disease? We have non-ST elevated myocardial infarction. The patient has chest pain. I'll ask Maximilian, what do you think about the treatment? Maximilian Blega, you are here, no?
Yes, I'm here. I'm listening.
Yes, try to understand on the base of the lecture that you have in the last days, the last lecture. It's an acute coronary syndrome, actually a small, probably myocardial infarction. The vessel is open. What you can give to this patient which come to your and ask you, doctor, give me a treatment to be well on the long run, and you give her a treatment. What do you think? What used to give drugs in a myocardial infarction or
Didn't you say ACE inhibitors can be used?
maybe, but are not essential. If the patient is with high blood pressure, if I recall, it's not high blood pressure. If I recall correctly, has a trend to orthostatic hypotension, and ACE inhibitors can increase this tendency. I won't give this, especially that I don't need this. She doesn't need this. Okay, something else.
Aspirin?
Aspirin, very good. It's a patient, it's a ischemic patient, an acute state. In every patient you give aspirin, very good. Something else? Shall we give her statins or not? What do you think? Ovidiu, Ona?
Yeah.
What do you think? Shall we give statin to this patient or not?
No.
No. Why? I agree with you, but why? To see if there is a reason or only a guess.
We can provoke an embolus.
With statins? No. No. No, but this patient has not an atherosclerotic disease, actually has no atherosclerotic plaque. She doesn't need statins for decreasing the rising of the atherosclerotic plaque because she doesn't have atherosclerotic plaque. Has completely different cause of myocardial ischemia. It's not a frequent one and will not be asked. You will not be asked by at the exam, but still it's good to know. Maybe you don't ask. What else? Somebody, I don't know who, proposed aspirin, which is good because it's an antiplatelet drug. What else?
Maybe blood thinners like heparin or warfarin.
What?
Blood
Tell me
thinners
again.
like heparin.
Yes, yes, for sure. It's good to give antithrombotics during the acute stage. But when we discharge the patient, what else to give? To continue to give antithrombotics or not? More than aspirin? Okay, let's, sorry. I will put for you what we give to this patient. Usually when it's coronary dissection, it's not recommended to do angioplasty. You didn't tell about angioplasty, but I want to tell you. It's possible, but it's not the main treatment. Usually medical treatment is the rule. Aspirin, beta blocker. Usually every patient after a myocardial infarction has to have beta blocker because increase the ameliorate the prognosis. And these patients usually are followed by computer tomography, coronary angiography. Sometimes you can do even coronary angiography, but it's with more risk and it's less indicated. Very good. And the patient went well. This is the ECG after 1 month. You see that the ST elevation and the negative T waves, everything vanished, and the patient doesn't have any Q wave, important Q wave, and it's almost normal. It's a little bit flattening of T waves. This is the only consideration that you can do it on this. And what about the heart rate? Who tell me how much is the heart rate in this instance, the same patient? I wait for you.
Is it around 50?
Exactly. Very good. It's around 50. Why? Because the patient has a treatment with beta blocker. This is the action of beta blocker. Decrease the heart rate. Has to be decreasing and depends of how well tolerate the patient. Some patients don't tolerate this kind of heart rate, about 50 per minute. Most of the patients are tolerating very nice. And for this reason, we target for the beta blocker treatment to have a heart rate between 50 and 60, let's say. Okay, very good. Let's go to the next one. I don't know why, but these patients all are young for this disease, but still, this is the case. 46 years old man, this time smoker, with hypercholesterolemia, with a previous MI 4 years ago, and then he didn't underwent primary reperfusion. What is primary reperfusion? Who knows? I have to take your list to put it to answer to me. Nicholas. Nicholas from Crete. Hmm?
Yeah, my family. He
Yes,
caught me.
because the name is with Akis at the end, and
Yeah, you know the secret.
yeah, know everything, guessing. Okay, but tell me about this hyperfusion. What is hyperfusion?
It's like a treatment to restore normal blood flow,
Yes,
angioplasty or something.
angioplasty or thrombolysis, but to be primary perfusion has to be in a specific time window. Do you know how much is this time window?
Uh, 48 hours or something from an
Yes,
emergency.
it's 12 hours.
12 hours. Okay, yeah, a
12
little off.
hours. After that, the necrosis is completed. You cannot save anymore. Only in those patients which continue to have chest pain after these 12 hours, you can do it because sometimes there is something which is open and close, and you have to fix it because it will close forever. Okay, good.
Okay.
But he actually have a coronary angioplasty with stents uh, after a while, after a few days, but already the necrosis was done. And now, after 4 years, he was admitted for dyspnea and lightheadedness, some dizziness, normal blood pressure, heart rate. The apical impulse is lateral and inferior, and we can hear the third heart sounds at the cardiac examination. What does mean the third heart sound, Nicholas?
It has to do with increased atrial pressure. So
This
maybe
is the fourth one.
that's the fourth heart sound.
Yes, yes.
That's a good question. Uh, is it has something to do with, I don't know, heart congestion or?
Yes,
It
wait.
impaired blood flow in the atrioventricular valve.
Uh, no, actually, it's impaired left ventricle function.
Okay.
The fourth heart sound usually means some diastolic problem which need a more forceful atrial contraction because it's because of atrial contraction. But the third heart sound usually means LV dysfunction, systolic LV dysfunction. And when you can hear this sound, we consider that's a sign of heart failure, left ventricle heart failure. Sometimes there is only one instance, maybe one I know, maybe there are more, in which the third heart sound doesn't mean LV dysfunction. It's only because of flow. This is in mitral regurgitation. In mitral regurgitation, because the flow which comes from atrium to ventricle, it's very, very big. Um, it appears this the third heart sound. Okay, doesn't matter. In this case, it's not mitral regurgitation, it's only LV dysfunction. Let's go. Oh, sorry. Immediately, to put the slides. This is the ECG. Tell me, but let's go the next student, which is Bogdan Vladimir Petre. Are you here? Can you tell me about this ECG? Bogdan or Vladimir? Vladimir, okay. Tell me something about this ECG. Take a look, take your time, and try to read this ECG. At least tell me about the heart rate. "75". Yes, it's less. It's more than 75. It's about 80, but it's okay. You're not far away. What about the QRS axis? It's raining at your place. And it's a hum. It's a noise. Okay. Um, what about the axis? You can tell it's not easy. It's a little bit difficult in this case. We can skip the axis. Tell me about the rhythm. Um, more or less, but actually you cannot calculate axis in this case because it's modified by something. I will tell you immediately after. Tell me about the rhythm. It's a sinus rhythm or not? It's a sinus rhythm. Let me tell you a simple thing. If you have a P wave, which is before every QRS complex in a convenient distance, like in this case, probably it's a sinus rhythm, but the P wave has to be, I'll tell it simpler, to be positive in lead 2 and negative in AVR. It's probably to be a P wave with another atrial origin, not sinusal, not sinus. Okay, good. But this is sinus. It's very clear. What else, Vladimir? What about the rest of ECG? What is abnormal? It's a little bit wide, and there is a notch, if you can see on the descending limb. Yes. But it's not unusually this QRS complex. I see only one wave. I don't see maybe in V1, but the rest of the precordial leads, I see only one wave, negative wave. I don't see any R in this QRS complex. It's not a complex, it's only a wave. Which wave do you think it is, this one? That you see in every lead, V2 to V4, V6. Do you see any R wave? No, because there are no. Yes. Actually, when there is only one negative wave, you cannot tell if it's a Q or S, because by definition, S is the negative wave which precedes the R wave, and a Q is this one, and S is the negative wave after the R wave. If it's not R wave, you cannot judge by the R wave, and you call it in those leads QS wave because it's not clear. Yeah, we can call like that. And what consider that means this QS wave in the all precordial leads except V1. Yes, it's a myocardial infarction. It's a necrosis wave. Q wave is typical for necrosis wave and is clear on myocardial infarction. And can you tell me about, take a look to the whole ECG, about the territory, which wall is involved in this myocardial infarction? Yes, but it's indeed the whole anterior wall because V1 to V6 means anterior wall, but still is belonging to anterior wall lead 1 and AVL. This is lateral, but they are not affected very much. AVL is not, lead 1 has a Q wave, but we can see Q waves in lead 2, 3 and AVF. What these are meaning, Vladimir, do you think? Do you know? I mean, Q wave, if you are attentive, there are Q waves in lead 2, lead 3 and AVF as well. That means necrosis is not only in the anterior wall, but in the other part of the inferior. These 3 leads means inferior wall is affected as well. That means it's an anterior and inferior wall. That means a very big myocardial infarction. But this infarction was 4 years ago, and the patient has no troponin or other necrosis marker right now. Still, there is a mild ST elevation if you take a look. Let me ask Elias. Elias, are you here? Elias Hussam? Elias? Okay. He went. Okay. Let me ask Valeria, Mariana, Farina from Sassari. Valeria,
Yes.
take a look to the ECG. Tell me, what about the repolarization, that means ST and T wave in this ECG?
Sorry, can you repeat the question, please?
Take a
Isn't
look.
it like the same in like the last ECG? Like
What?
inverted T wave and
Yes,
elevated
yes,
ST.
yes, yes. Yes, you are not far away. It's very like with the previous ECG. The difference is like that. This was, that one was during the acute coronary syndrome. This is after 4 years after the acute coronary syndrome, and still there are Q waves, inverted T waves and a mild ST elevation. That means like a frozen aspect of the ECG, like an acute phase, but still it's a chronic phase. These usually it's significant for a complication of a myocardial infarction. Do you know which complication it's it showed this ECG? Chronic complication, if you know.
An aneurysm, maybe.
Okay, who told me?
I said aneurysm.
But who you are?
I said
Yeah.
necrosis.
Who you said what? The
Necrosis.
necrosis. Yeah, no, it's not only necrosis. Yes, necrosis. It's because you have Q wave. This is the mark of necrosis. But the ST elevation and the negative T waves, which are persisting after months and years after myocardial infarction, is indeed a mark of LV aneurysm. LV left ventricular aneurysm, which is usually in the anterior wall infarction. And we proceeded with the examination of the patient, and this is the echo. Maybe it's not clear, only it's put it here. This is for chamber view, it is called, with atriums, atria, which are downstairs, ventricle after that, and like a ball in the apex of the LV, it's written Romanian, sorry, is the aneurysm. Okay, done. Left ventricle is this one, but it's expanded here with this aneurysm. Okay, and they continue to examine the patient, and they done a computer tomography and the magnetic resonance imaging. And what you see, it's written with a Romanian contraction. This is left atrium, this is right atrium, this is left ventricle, and these here, you can see here, is the apical left ventricle aneurysm, which it touches the chest wall actually. And here, here is the right ventricle, and you can see from this picture that the left atrium is the most posterior chamber of the heart. And here you don't see well is the right ventricle, which usually is the most anterior chamber of the heart. Okay, and they continue to examine the patient with the magnetic resonance, and this is the left ventricle, and this is the left ventricle, sorry, and this is the aneurysm here, which touches actually the chest wall. Actually is a giant left ventricle apical aneurysm. And even though you can see or not,
We see the slides.
which slide? This was written.
The giant left
Okay,
ventricle.
very good, very good, very good. I wasn't sure because I looked for something else. Okay, look, there in the complication of myocardial infarction, there is a special chapter which is called mechanical complication of myocardial infarction. Usually is composed by the first three, which are surgical emergencies, but some added the fourth one, which actually is the left ventricular aneurysm. Okay, I'll call you Valeria. If you know, we'll speak about this mechanical complication of myocardial infarction. Tell me, what do you know about free wall ventricular rupture, heart rupture? What do you think? Do you know something about this? Valeria, are you there?
Not really.
No, you don't know. Who knows about free wall rupture of the left ventricle?
It usually occurs within like the 5th to 14th day following up myocardial infarction.
Yes, but what is the consequence of this?
Cardiac tamponade?
Yes, cardiac tamponade and death. Actually, it happened in some series in 4% of the patients with acute myocardial infarction, and usually means immediately death in 1 minute. The patient can appear to evolve very well, but in a specific moment, the patient died suddenly. One of the causes of this suddenly death is free wall rupture. And actually, from all deaths from myocardial infarction in acute phase, it's 1/4 of the cases. It's not rare. Only we cannot see it very frequent, and usually we cannot do anything for this patient because they are dying too rapid, too fast. We cannot treat it. You cannot take out the blood from the pericardium because just you take out all the blood from the body. But some cases, not frequent, some, let's say 1 per 1,000 case, didn't doesn't die because the rupture is covered by the thrombus, and there is a, a time, hours or even days, in which the patient has this free wall rupture covered with a thrombus, and you can fix it. Otherwise, will rupture completely, and he will die in, after a while. I mean, after a few days. But if you diagnose this, you can send the patient to the operating room and just put a patch on the rupture because it's small. You can put a patch from pericardium usually. Okay, that means most of the cases it's fatal. In that cases in which is not fatal, you have to send the patient to emergency cardiac surgery. Okay, we'll go to the second one. I will ask Olivia Akashi. You are here, Olivia, from Nigeria.
Yes, I'm here.
Tell me about ventricular septal defect, like a complication after myocardial infarction. Do you know something or not? You have the lecture yesterday, no? It's not mandatory to know, but I want with you to rehearse these problems, yes? Tell me, what do you know about ventricular septal defect?
It occurs after transmural infarction.
Yes. But what are the consequences of this ventricular septal defect, and what is the treatment of it? It is anybody which knows
The
septal.
hole,
Yeah,
the hole in the septum, so the
yes, indeed.
left and right ventricle blood are mixed, like oxygen and deoxygen blood mixed.
Yes, in a way, but it's not that important. I'll tell because you judge like in congenital ventricular septal defect when there is blood which is coming from the left ventricle. It's oxygenated blood which is going the right ventricle, but the systemic blood will be deoxygenated only if the blood will come from the right ventricle in the left ventricle, which is not happened usually in this because it happens in time. You cannot do it like that. The problem is that the left ventricle lose efficiency and send more blood in the right ventricle than in the aorta. And from this thing means a diminished systolic output and means diminished cardiac output, and the patient has the consequence: low blood pressure, renal failure, cerebral reduced perfusion, so on, so on. And the thing is that the disturbances are mild at the beginning, but tend to aggravate, to worsen in time, in short time. And the final step of this the thing which happen is death after a while, days, weeks, less frequent months. Okay, which is the treatment? Who knows?
Maybe diuretics.
Diuretics you can give, but imagine you have diminished heart output, cardiac output. With diuretics, you diminish even more than that.
Close the
Yeah.
defect.
I don't understand.
close it with like a patch, just like
Exactly. That's the curative treatment, surgical closure of the defect. But the problem is like that. There is a problem in the surgery as well. If they will do it immediately, the result will not be that good because it's not clear which part is necrosed, which part is no, and this operation can, the ventricular defect can recur, can be stitched by a not cured, not normal uh, muscle, and appear again this hole in the septum. And for this reason, surgeons tend to postpone the intervention 2 or 3 weeks for healing the myocardium and to have a better operation. The problem is that in 3 weeks, 80% of the patient will be dead. And this is not settled yet. Some centers want to operate early. Some other centers consider that it's better to operate later. But this actually is the treatment, the therapy for this disease is surgical closure of the defect. Okay, very good. Next one. Next, I will ask Halime.
Yes.
Are you here? No.
Yes. Yes.
What about acute mitral regurgitation because of papillar or chordae rupture? What do you imagine? What do you know about it?
The blood goes back to the atria, which then could cause like high pressure and could cause also like pulmonary pressure.
Speak a little bit louder, please.
Yeah. Since the blood goes back to atria,
I understand. Continue.
yeah, pulmonary hypertension. Maybe it could lead.
Yes. Acute.
It could lead to like some, I don't know, electrical defects, like atrial fibrillation. I don't know, like since there's
Atrial fibrillation. Maybe it can happen, but this you imagine it's an acute situation. All the pressure from the left atrium, because it's a higher pressure, will go to the lungs.
Yeah.
It's not time to dilate the left atrium because this happened in long period. You don't have only hours. What's the consequence of the pulmonary hypertension, acute pulmonary hypertension?
Dyspnea.
Yes. Dyspnea. Actually, we call it differently. This syndrome, we call it acute pulmonary edema.
Oh, okay.
Yes, because the pressure is that high and the blood is going in the alveoli and the patient is very dyspnoid.
Pulmonary embolism?
No, why pulmonary embolism? This is completely different. No, pulmonary embolism means a thrombus, a clot, which is formed in the venous part and is going in the lungs, in the arterial part of lungs. This is not dealing with arterial lungs artery, is dealing with lungs, veins, and capillaries. And it's acute pulmonary edema. It's a form of acute heart failure, left ventricle heart failure.
Also,
You have to know about this. Okay, tell me. Sorry.
I said it also may occur with cardiogenic shock. May appear.
Yes, can be as well cardiogenic shock, but not because of pulmonary hypertension and acute pulmonary edema. No, because of the decreasing the heart output, because a lot of blood is going in the left ventricle instead of going in the aorta. Yes, can happen. Okay, but these two are most important thing. One, it's refractory pulmonary edema because all the time you cannot treat proper, and decreasing cardiac output and maybe cardiogenic shock as well. What is the treatment for this?
Valve replacement.
exactly, on emergency basis. Actually, all those three mechanical complications of myocardial infarction have to be operated. But if you we put it in a specific order, the most emergency one is the free wall rupture. The second one is acute mitral regurgitation, because it happens in our days. The patient doesn't live too much. And the third one is ventricular septal defect. Usually patients are living 1 week, 2 weeks, 3 weeks, 1 month, that is more than a few hours. Okay, and we can put this complication like left ventricular aneurysm. Not everyone is agrees with this to be put in a mechanical complication, but still it's a mechanical complication. Only this doesn't need emergency surgery. Okay, I will show you now some nice picture about the aneurysm. Wait a minute. Okay. First of all, let's speak about complication of the left ventricular aneurysm. And who can tell me about this? I will go to the list. Ece, Ergin,
Yes, I'm here.
Megidia, I don't know.
No, I'm not from there.
Okay, no problem. Tell me, Ece. Tell me thing that can be complication of LV aneurysm.
So I think firstly that there would be a decreased ejection fraction, so maybe heart failure.
Indeed, because the LV aneurysm is like a buffer, and some blood during systole is not going in the aorta as normal, but in this chamber, which is the aneurysm itself. Very good, actually. What else?
Maybe a thrombus could form.
Yes, usually when the blood is not flowing properly, a thrombus is formed, and the consequence of thrombus is
Embolism.
exactly
I mean,
systemic
stroke.
embolism. Yeah.
Or a stroke.
Yes, a stroke is an example, but it can be a mesenteric infarction, renal infarction, or acute ischemic, acute ischemia. Okay, peripheral. What else?
Well, I'm not sure, but maybe arrhythmia.
Very important. Yes, you're right. You're very good. Yes, arrhythmias, malignant arrhythmias. These patients are dying usually not of heart failure, but arrhythmias because of the inhomogeneous depolarization with this aneurysm. And actually, this, if you recall the ECG, there is a notch on the descending limb of the QS wave. This means usually a small focal conduction defect, which is associated with arrhythmias. Okay, go on. You told me almost everything I want, but still there is one thing that happened. The aneurysm can rupture. And yeah, no, just maybe you'll told me, but I prefer to put like that. And if you see, you told me exactly what I considered before. And the treatment in this case is the same, like surgical resection, only it's not an emergency basis. And I'll show some images from surgery, from the operating room right now. And this is the operating field. This is the aneurysm, which bulges outside the heart. And this is the aneurysm wall, which was cutted. And these are clots, the black ones you see here. And usually the treatment is to do um, make a new wall between the left ventricle and the aneurysm. This all you see here is the aneurysm, and this is a patch which is stitched here, and actually is the limit of the left ventricle, which is posterior to this. We don't see it. We see only from the aneurysm side, because if you remember, the aneurysm was near the chest wall. Yeah. Okay. It's nice. Okay, and after the intervention, the echo show like that. This is right atrium, left atrium, right ventricle. This is a transesophageal echography, and for this reason, the ultrasounds are coming from behind the heart, and the first chamber, which is behind, is posterior, is the left atrium. But this is the left ventricle, and this is the patch which actually made the end of the ventricle. This is the left ventricle. It's reconstructed with the patch. Okay. Good. I have few cases more, but the time is too advanced, and I propose to finish here. Or if you have time, we can discuss another one. What do you want?
It's up to you.
What? Stop here. Okay, good. No problem. I hope it's good for you to discuss like that. I want from you to tell your opinion, and I will ask all the time in one or other moment in the presentation. Otherwise, you'll not be involved enough, and you'll not got enough from these seminars. Okay? Good. Then, if you have any question, yeah.
I have a question. For
Of course.
this last case that we discussed,
Yes.
the left ventricular aneurysm, if it's
Yes.
not too large, can we, like, do we still have to perform surgery if it's a small aneurysm, or can we opt for?
It's a question. No, if it's very small, you don't have. If it's very large, you cannot, because it takes important part of the left ventricle, and you cannot make a very small left ventricle. In this case, was a huge aneurysm, but the left ventricle was enough for cutting, because you cut the apex of the ventricle. If it's very small, you don't have. Only if this aneurysm, a smaller one, has some complication like arrhythmias, you can do it, because the operation itself is not without risk. It's about 10 to 20% of mortality risk, but the risk of living in place, it's even higher. Yes, that is my question for these. Okay. Other questions? Alime, you want to ask me something? Okay. If nobody has, huh?
Yes.
No, I just thank you.
Okay. If nobody has questions, okay, we finish here, and we'll see you tomorrow. Have a nice day. Yeah.
The
Shalini, tell me.
morning